Today we're going to talk about opioid withdrawal. So this is the DSM-5 TR, opioid-related disorders. We have already done opioid use disorder. We have done opioid intoxication. Today we're going to do opioid withdrawal. All this is Dr. Mubin Sayed from DrBeen.com. Welcome to one more show. Today we will continue with our talk for the DEA requirement, and that is the pain management, and especially within the context of opioid use disorder, and then the management of that. Today is the 14th topic. We have done 13 before, which have reached, I think, about 9 credits have already been recorded. Today we're going to talk about opioid withdrawal. And I am going to use DSM-5 TR as the reference book. So as we are discussing this, you might actually think about some other symptoms as well that are not in the DSM-5 TR, and I'm not talking about them. And that is not because they do not know it or I do not know it. The only thing is, this is the criteria. These are the diagnostic features that are necessary to be able to diagnose withdrawal. So let's look at those. So I'm going to share my screen. And actually, before even going there, I did not say it. So I have no disclosures. I have no conflict of interest to declare. And let's start. So this is the DSM-5 TR, opioid-related disorders. We have already done opioid use disorder. We have done opioid intoxication. Today, we're going to do opioid withdrawal. So just very quickly, we did this last time, intoxication, and this is the withdrawal. We are going to go over this section, and let's do that with my drawings. So first of all, opioid withdrawal diagnostic criteria. So criterion number 1, or A, cessation or reduction in opioid use that has been heavy and prolonged, for example, several weeks or longer. So cessation, so somebody who was taking heavy opioids, either with their prescription or for other reasons or illicitly, somebody who was taking heavy and prolonged opioids, and then they stop them or they reduce them. That is one criteria. So as part of the history or as patient's history, you would figure out that were they using opioid and did they reduce it or stop it? Second part of the criteria, administration of an opioid antagonist after a period of opioid use. This is where patient or person was using opioids for some time, and then an opioid antagonist is used. Opioid antagonists are the drugs that are going to counter the effect of opioid. So that is essentially like opioid withdrawal, because antagonists would come in and displace or reduce the efficacy of the opioids. So these are the two parts of criteria 1. So summary of this is that we have to know that the patient was on opioids for some time, and now they stopped it or reduced it. Criteria B, 3 or more of the following developing within minutes to several days after criteria A. So opioid dose is reduced or stopped, or an antagonist is used, that is criteria A, and within minutes to several days, the feature set, the signs and symptoms that I'm going to discuss now, 3 or more, if present, that would be then criteria B satisfied as well. So let's look at them. First of all, dysphoria. So here, this individual who used to use opioid and has now reduced them or stopped them or is taking antagonist, he is dysphoric. And dysphoric is a saddened state. So there is dysphoria. And why do I have him sit like this? It will become clear in a second. First, dysphoria, then nausea or vomiting, and number 6 is diarrhea, although it doesn't matter which number, but I want you to adhere to the numbering. And now I think you can know why I made it like this. So nausea or vomiting, and or diarrhea. So nausea or vomiting, one criteria, diarrhea, another criteria. So even over here, if somebody has dysphoria and then nausea or vomiting and diarrhea, or we already have 3 symptoms. So 3 or more. Then number 3, muscle aches. Number 4, lacrimation. Lacrimation is, the tears coming from the eyes, or rhinorrhea, that is the fluids dripping out of the nose or coming out of the nose. So rhinorrhea or lacrimation is one, and muscle aches is another. Then pupillary dilatation. This is very important. Just like we know that when somebody is using opioid, they have meiosis or they have, pinpoint pupil. Similarly, when the opioids are reduced or stopped or antagonists are taken, there is a response which then causes pupillary dilatation. So pupillary dilation, piloerection. Piloerection is the hair, they stand and goosebumps develop. So that is piloerection. So piloerection or sweating. So any one of them, pupillary dilatation or piloerection or sweating. So that would be one criteria as well. So here, this is the sweating, and these are the goosebumps or the piloerection. And this is my depiction of pupillary dilatation. Then, do you see that I made him under the covers? The reason for that is I did not know how to draw very well the yawning and fever and insomnia. So I just put him and had him lie down on a couch under a comforter. So yawning is another criteria, fever is another criteria, and then insomnia or not able to sleep very well. So the total criteria, once more, we're done with the criterion B and its parts: dysphoric mood or unhappiness, sadness, nausea or vomiting, muscle aches, lacrimation or rhinorrhea, pupillary dilation, piloerection or sweating, diarrhea, yawning, fever, insomnia. Now I'm going to tell you a trick that I used to use when I used to study, and that is whenever I had to remember a list of items. You can make a mnemonic and you do that. I used to do this that I'll go from head to bottom, head to toes, and as various systems will come on the way, I would remember what will happen. So for example, in this case, if you start from the head towards the lower sides, we have hair on the head, so piloerection. Then if you go next to it, there is skin, that is sweating. Then if you go down from there, there are eyes, and that will be pupillary dilation and lacrimation. Then if you go below that, there is nose, so rhinorrhea. If you go inside the skull, that is brain and dysphoria. Then if you go further down, there will be the body, the muscle aches. If you are at the mouth area, yawning. And then if you go further down, diarrhea, and on the systemic level, fever, and I forgot insomnia, that would also be at the brain level. So at the brain level, dysphoria and insomnia. So majority of the things, except diarrhea and fever, majority of the things you can just remember by, going from the head towards the mouth. Criteria C. The signs or symptoms in criteria B cause clinically significant distress or impairment in social, occupational, or other important areas of function. So the criterion B, in which we saw that list, if that is satisfied. And remember, for the criterion B to be satisfied, we have to have criterion A to be a prerequisite. That has to be satisfied as well. So once the criterion B is satisfied, then we also have to have this satisfied as well, that the signs or symptoms in the criterion B cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. This has to happen for you to be able to diagnose the patient as in opioid withdrawal. Criterion D. The signs or symptoms are not attributable to another medical condition and are not better explained by another mental disorder, including intoxication or withdrawal from another substance. So meaning you are making sure that something else is not causing these signs and symptoms, something else is not, something else is not able to stand behind these signs and symptoms with a better power than the opioids. So these are the four criteria. So if you think about it, criteria A is that somebody was using opioids and they were reducing them or stopped them or were taking antagonists. Criteria B were the signs and symptoms of them. And any three out of that list or more will satisfy B. Criterion C was saying that if there is B present, then is that socially or occupationally or societally clinically significantly affecting the patient or not? That would satisfy C. And then in the criterion D, the sign or symptoms are not attributable to something else. Now, once you have diagnosed the patient, and when you are going to go for the ICD-10-CM coding, the code is F11 or F11 point number and then 3. This number, as we saw with the intoxication as well, this number over here, the fourth letter in the code, represents if there is comorbid opioid use disorder. So here, if opioid withdrawal with mild opioid use disorder, then you'll use 1 at the letter number 4. Opioid withdrawal present with moderate or severe opioid use disorder as well, then you'll put 2. And it is possible to have opioid withdrawal without use disorder. How is that possible? So look at that. You would put 9 here. Opioid withdrawal in the absence of opioid use disorder, for example, in patient taking opioids solely under appropriate medical supervision. So this is an important thing to keep in mind, that someone who is taking opioids for some period of time will experience withdrawal when they stop opioids or when they reduce the quantity or when they have antagonists. But if they were taking those opioids solely for some, for example, pain management purpose and under prescription and under supervision, then that will not be called opioid use disorder. Withdrawal may be present because as you stop the opioid, patient would feel or the person would experience withdrawal, but you will not say that they have opioid use disorder as well. Now, diagnostic features. Once again, the criterion B, we are just going to look at that in a little more descriptive way now. So criterion A1, the opioid use may be illicit or licitly obtained. So illicit is incorrectly out of the prescription. Licitly is with prescription correctly. So illicit or licitly obtained drugs prescribed to treat pain. Prescribed to treat pain. A withdrawal syndrome can also be precipitated by administration of opioid antagonist. So I would really request you to have this in your mind, that there is a opioid were being used heavily, then they were reduced or stopped, or antagonists were given. And I see, Monica, your hand is raised. How can I assist? Okay, so Monica, either type, and I would look at the comment in a second. So the opioid use may be illicit or illicitly obtained drugs prescribed to treat pain. A withdrawal syndrome can also be precipitated by administration of opioid antagonist, for example, naloxone, naltrexone, nalmefene, after a period of opioid use. It can also occur after administration of an opioid partial agonist, for example, buprenorphine, to an individual currently using a full opioid agonist. So somebody who's using opioid agonist, and if you give them partial agonist, then that can cause the withdrawal as well. Anxiety. So in the beginning, when it starts, there is anxiety, restlessness, and achy feeling, often in the back and legs. So the patient starts presenting with this, that they're anxious, they are restless, and there is achy feeling, mostly the back and the legs. Irritability and increased sensitivity to pain. This is very important, increased sensitivity to pain. So this is how these symptoms start. And then we know these symptoms, we have done them before. Dysphoric mood, nausea, vomiting, muscle aches, lacrimation, rhinorrhea, pupillary dilation, piloerection or sweating, diarrhea, yawning, fever, insomnia. Now, some more features of these signs and symptoms. Piloerection, that is the hair, the goosebumps. The piloerection and fever are associated with more severe withdrawal and are not often seen in routine clinical practice. So goosebumps and the fever are often with more severe withdrawal, and usually or often not seen in the clinical practice, because individuals with opioid use disorder usually obtain substances before withdrawal becomes that far advanced. These symptoms of opioid withdrawal must cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. For us as cold turkey, absolutely. The symptoms must not be attributable to another medical condition and are not better explained by another mental disorder. Having symptoms that meet diagnostic criteria for opioid withdrawal alone is not sufficient for a diagnosis of opioid use disorder, but concurrent symptoms of craving and drug-seeking behavior are suggestive of comorbid opioid use disorder. This is very important. Having symptoms that meet diagnostic criteria for opioid withdrawal alone is not sufficient for diagnosis of opioid use disorder. So if you see the criteria for today's talk, that is withdrawal criteria. If you see signs and symptoms of this one, you cannot automatically say that they also have opioid use disorder, because here you are seeing the withdrawal there. Concurrent symptoms of craving and drug-seeking behavior are suggestive of comorbid opioid use disorder. Now, associated features. Opioid withdrawal may occur in any individual after cessation of repeated use of an opioid, whether in the setting of medical management of pain, during opioid agonist therapy for opioid use disorder, in the context of illicit use, or following attempt to self-treat symptoms of mental disorders with opioids. Opioid withdrawal is a distinct condition from opioid addiction or opioid use disorder and does not necessarily require the drug seeking behavior associated with opioid use disorder to be diagnosed. Now, this is a very important point. For opioid use disorder, drug seeking behavior is necessary. But for opioid withdrawal, it is not necessary that that behavior is present. Thus, opioid withdrawal may occur in individuals without opioid use disorder and should not be confused with it. Males with opioid withdrawal may experience piloerection, that is the goosebumps or hair standing on their ends, sweating, and spontaneous ejaculation while awake. So these are associated features. Now the prevalence. 60% of individuals who had used heroin at least once in the prior 12 months experience withdrawal. So individuals who have used heroin within the last 12 months, 60% of them experience withdrawal. Then at some point in time, individuals regularly using opioid, prescription for pain, or illicit use for a period of time are at risk for developing physical dependence, including withdrawal on cessation or marked reduction in use. Similar message, just repeating in various ways. So this is the prevalence. Now, development and course. The development of the symptoms and the course of the symptoms, intensity of the symptom, how long will they be, it will depend upon what is the half-life of the opioid that the person has taken, how long have they taken it, and if I hope you can connect the dots that we have done this discussion before, that as soon as we start taking opioids, within the same day, our body starts responding to them and reacting to it and adjusting to it. So the longer somebody has used, the longer the body has adapted to it. This is why time factor is important. So how long opioid were used, what is the half-life of the opioid? That means how quickly they are cleared out or not quickly they're cleared out. And what is the dose of the opioid used? These are very important. Speed and severity depends on the half-life of the opioid use. For short-acting opioids, such as heroin, the effect will start within 6 to 12 hours of the last dose of heroin. Within 6 to 12 hours, they would start feeling the withdrawal because heroin is a short-acting opioid. Then the symptoms will peak in 1 to 3 days. And then they would gradually start subsiding by 5 to 7 days. Now, this is also true that sometimes these symptoms continue on for weeks to months. And again, as I said, it depends upon many factors, not just this that somebody was taking opioid and now not taking opioid. What kind of opioid, how long did they take it, what was the dose of it, etc. Development and course continuing. Speed and severity depends on the half-life of the opioid. For longer-acting opioids, for example, methadone or buprenorphine, symptoms may take 2 to 4 days to emerge. Remember, for the short-acting, within 6 to 12 hours. For long-acting, 2 to 4 days to emerge. More chronic symptoms, for example, anxiety, dysphoria, anhedonia, craving, insomnia, can last for weeks to months. So the takeaway, short-acting will develop withdrawal fast, long-acting will develop withdrawal with some delay. The severity of opioid withdrawal also varies depending on the duration of opioid use, Opioid withdrawal symptoms among individuals receiving long-term prescription opioid treatment for pain can be minimized by tapering the drug slowly. So if somebody is on opioid prescription drug and for a long time, instead of just stopping abruptly or stopping with a greater drop in the dose, one can slowly taper the dose and reduce the effects. Among those with an opioid use disorder, opioid withdrawal and attempts to relieve withdrawals are typical. Now, this is an important thing to consider. Withdrawal is withdrawal, as we just saw what it is. There is an attempt to alleviate the withdrawal or relieve the withdrawal as well. The course of withdrawal can be part of an escalating pattern in which an opioid is used to reduce withdrawal symptoms, in turn leading to recurrent episodes of withdrawal at a later time. So what patient is doing is they are making an effort to quit or stop, patient or the doctor or all together, but then the withdrawal occurs and then there is a attempt to relieve the withdrawal symptoms by taking the opioid, then stopping again, then withdrawal occurs again. And so there is a recurrent or there is a repeating cycle of this outcome. Anxiety and restlessness also seen. Now, this is the differential diagnosis that can other drugs have the same symptom set, this criteria of 9 signs and symptoms, plus criterion A and C and D. So can something else also do this? So anxiety and restlessness is also seen in sedative hypnotic withdrawal, anxiety and restlessness. But rhinorrhea, the fluids coming from the nose, lacrimation from the eyes, or pupillary dilation are not seen in sedative hypnotics. So anxiety and restlessness may be present in sedative hypnotics as well, their withdrawal. But this one, rhinorrhea, lacrimation, pupillary dilatation, will then help you differentiate that this is opioid versus the sedative hypnotics. And again, if rhinorrhea, lacrimation, and pupillary dilatation is not present, then it could be sedative hypnotic withdrawal. Similarly, dilated pupils, mydriasis or dilated pupils, also seen in hallucinogen intoxication and stimulant intoxication. So these drugs or substances, hallucinogen or stimulant intoxication, can cause dilated pupils. However, other signs of opioid withdrawal, for example, nausea, vomiting, diarrhea, abdominal cramps, rhinorrhea, and lacrimation, are not present in these intoxications. Last part of today's talk, opioid-induced mental disorder. Opioid withdrawal is distinguished from opioid-induced mental disorder, for example, opioid-induced depressive disorder with onset during withdrawal, because the symptoms, for example, depressed mood, in these latter disorders, that is opioid-induced mental disorders, are in excess of those usually associated with opioid withdrawal. So those mental disorders or the symptoms are excessive compared to opioid withdrawal. Predominate in the clinical presentation. So mental disorder or those symptoms will be dominant as the patient presents to you and are severe enough to warrant clinical attention. So this is an important differentiator for opioid withdrawal versus opioid-induced mental disorders. What is the takeaway? Mental disorders would have more or excessive intensity of the symptoms. So this is the discussion. I'm going to stop recording now. Next time, we would start talking about the management of these disorders. I'm not going to go over the mental disorders. I would request you to pick up DSM-5 TR and look through them. We will now go to the management of the opioid use disorders. Thank you very much, and I'm going to stop recording.